Sollis. Better insights for better outcomes. This session was recorded live at our Advances in Population Health Management workshop in London, November 2018.
Great pleasure to invite Jason Tong to the stage. I think this should segue neatly from Jeremy's piece there. Jason's going to talk about social prescribing, which many of you I'm sure will have an interest in. So, insights from the shop floor on social prescribing in South West London.
Thank you very much. Thank you. I wouldn't call myself shop floor or shop front at all, but really working. My role is really about working with CCGs across London and local authority and VCSE organisations to develop social prescribing services across London. And I started this role about 2 years ago, and with Healthy London Partnership support, I think social prescribing is very early on at that stage, and we don't even know what that means, you know. And even now, I think there's a lot of controversy about what the term means, definition of it, and how does it look like. So I just want to shed some insight about what that is. But first of all, I just want to say that the difference between me and Jeremy is that I probably have a little bit more hair, and probably slightly younger, maybe. So yeah, I just want to say, so social prescribing from NHS England point of view, and that's just really from an NHS England point of view and an NHS point of view, it's about that sort of link worker model that they want to develop further. So we all know that, you know, we'll be Googling something, we'll use sort of apps to help us on self-care, and that's a very sort of personal use of information to help yourself to get better in any ways or form. But also the other way is for health professional to advise you on where to go. You know, if the health professional knows down the road there's a really good gym that you can join, or some really good charities that they know of that you should be part of, they recommend you to do that. So social prescribing is slightly much more carved out of that particular sort of model, in that they want someone to have very local knowledge about the local non-medical offer. So go down from sort of housing issues, debt issues, relationship issues, to more activity-based, like swimming, physical activity, arts, for example. Lunch club, we just saw that lunch club is a really good example of social prescribing. So a range of things that are absolutely vital to one sort of wider sort of health, determinant of health issues, but not so much on sort of particular condition that sort of relate you to other sort of organisation or activities. So this is the way that the NHS England is sort of travelling at the moment, that we are really looking at someone who's got really expert knowledge locally, maybe about 4 or 5 GP practices. That's really the key of having that localness and knowledge to be able to refer. At the moment, we're wanting, we hope to establish services within GP practices, but that doesn't stop social prescribing service to expand to secondary care, to IAP services, to mental health services and community services. So a lot of different options that could happen as well in the future. But our first step, we're doing baby step at the moment. I think in the next few weeks there will be more plans revealed in the long-term plans, and that we are going to be more focusing on primary care. So our journey, as I said, sort of started, my journey at least, sort of started 2 years ago when I joined Healthy London Partnership. And we're part of NHS England as well, work very closely with them. And one of the first things we start to think about, you know, is exactly what Jeremy said. It's about segmentation. How do we cut sort of conditions up to make sort of a compelling sort of story about how patients can be referred to activities and how that activities can improve costs and improve the system in terms of reduction in secondary care costs and primary care costs. So that's kind of what we did in the first place. So what we started looking at is a really segment way of looking at what type of conditions patients have and what kind of activities they will be referred to. So we actually look at the whole of London. We've got the data for whole of London, and look at each GP practices and start segmenting patients with different groups. So in here we've got management for chronic conditions, new beginnings, diabetes, time banks, ecology services, arts on prescription, and things like that. So we start sort of segmenting activity as well as segmenting patients groups as well, and identify for each GP practices how many patients would benefit from social prescribing. This is really to kickstart sort of social prescribing in local services. For those who hasn't got social prescribing services in their borough, we want to use this to kickstart, to give their business case a bit more oomph and sort of data behind it. What we quickly realize is a lot of services are already starting. Within that 2 years, a lot of services are developing. Commissioners are starting to tell us, hang on a minute, you said this is, 5 million you're going to save us, and I'm not even seeing 1 penny yet. So I've got a service here. How do I evaluate it and give my business case a really strong support? So very quickly we thought, oh right, okay, well we need to go back to basis. And I think that's when we actually get together with a number of commissioners on the table about a year ago, about October this time last year. We actually get them together and say, hang on a minute, what do you actually need immediately to set up your social prescribing services? And they quickly tell us, actually, is secondary care and primary care access, and if you can tell us, if you can help follow these patients for us and identify how much their savings there is, it will be fantastic. So that's how the journey went. I think this particular methodology is fantastic. As I said, it's really about matching patients with intervention. There's a clinical signature that includes different demographics and different risk stratification methodology as well. We commissioned I5 Health at that time to deliver this work. In terms of our next approach, so we quickly need to come up with this, and it took us about a year now to deliver this methodology, but I think it's starting to articulate what actually the business case required for each and every single CCG and tailor it to their patients as well. So we've got 2 different methodology. One is Tower Hamlets. We actually look at the intervention group, which is, they have established social prescribing for 25 years now, so it's a very well-established service. And they have about 2,500 patients within the books within 1 year. And we look at their patients as intervention group and compare it with the whole population of Tower Hamlets. And what we identify is a 12% reduction between the intervention group and the whole of population of Tower Hamlets. So that's really sort of exciting us and sort of identify some differences, not causality, but correlations between social prescribing, engaging with community, and actually reduction in access to secondary care and primary care. And then what we did is we then look at Merton. Merton has a slightly different approach. So they only started about a year ago, over a year ago, and they've only got 2 GP practices, and they have about 100 to 200 patients that access the service. So it's very difficult for us to sort of compare that intervention group with the whole of Merton. So what we decided to do is to really segment it into pre and post. So we look at the access of secondary care before they access intervention and after the intervention, and compare it and basically subtract it really and come up with a value of savings. But what we also did is, on a monthly basis, we asked the link worker to submit data as well for us, so that we can start monitoring their progress. So within a year there was about 50 grand of savings, and within 18 months there was already jumping up to 130,000 pound savings. So there is significant difference. The longer actually we see that the longer social prescribing is implemented, the more benefit there is over longer term. So the intervention, I think for me, this the beauty that social prescribing doesn't seem to end. Often so NHS intervention ends within a certain period of time. I think social prescribing's benefit does go on, and it's also depending on how long and how good the service is as well. And it does demonstrate that sort of Merton's sort of model is kind of working for the 2 GP practices. So what do they do now? Particularly for Merton, they have sort of expanded to 13 GP practices now, and I believe that they haven't got the outcome yet, but they already submitted to their board in the last week, and they want to expand it to all of GP service within 22 GP practices in Merton. So that's a success story in a way, but I think it can be implemented across sort of London as well. So what we're trying to do now is, where we can, we work with CCG and local authority to start modelling this within their locality. There are some sort of commissioning differences. Some are more commissioned services than others, so we'll work around that with the CSU. And then also with Sollis as well, we're working very closely with identifying case finding and more targeted approach of social prescribing as well. So it's like going back in the loop again. So we're going back again to identifying those patients that really would benefit from social prescribing. So that's all I want to say. Thank you.
Fantastic.
For more information and insights, visit our website sollis.co.uk.